In the following video, we will evaluate a patient. We will discuss at the end of the video, when we're also measuring and using contrast and strain imaging, what the actual pathology is. All the time when we perform echocardiography, we start in a left atrial position. We use, of course, a cardiac transducer. This is a special transducer which also enables 3D echocardiography. We need ultrasound gel, and then we start at the peristernal long axis view. We already have a setting which I prefer, so the color is gold. Everywhere you have a possibility to change the color. So gold, it's more brownish, so it's better for my eye, and because of that I can see the image, especially in this very bright environment, better. So first of all, we start with this peristernal long axis view. We started at the clavicle, moved the transducer caudally, and here we have the interventricular septum, the right ventricle, the left ventricle, the mitral valve anterior, posterior mitral valve leaflet, here the aortic valve, the ascending aorta, sinotubular junction, and the aortic root. The left atrium, we can already differentiate, seems enlarged. Here we have the descending aorta, the pericardium. We do not have free fluid around the heart or in the lungs, as we can see now. So to continue, I always optimize my gain setting for my eye. So I want to see the structures of the heart optimally. You can also appreciate immediately that the heart has a pathology. Especially septum is severely thickened. So this, of course, can be hypertrophy, but we have to differentiate if there could be another cause, for example, arterial hypertension present. In this case, the interventricular septum easily exceeds 15 millimeters. You see here 2 centimeters. It must be around 20 millimeters. So it's definitely severely thickened. Therefore, it's unlikely that this is only due to hypertension. Now we have the peristernal view. We activate the color Doppler. We can also switch off variance so that you have the optimal Doppler setting you want. So the variance is this greenish color. You can leave it on or switch it off. You can also change the color Doppler setting, but for me this is perfectly fine. So I also save the loop. I always have 3 cycles. Here you can adapt the cycles, and you can also change the overall setting into soft or more harder, so that you see different echogenicities of the myocardium. You can also switch it off, then we have to have more gain. But overall for today, I want to continue for now with the soft setting, so to speak. Also, the time gain compensation is also already optimized, and when we have this standard view of the peristernal long axis, we can tilt the transducer downwards and see the RV inflow. So this is the right atrium, this is the right ventricle, this is the tricuspid valve, the anterior and the posterior leaflet, and he's not that easy to scan. So it's not the optimal image, but still we can appreciate the tricuspid valve. We then use color Doppler and continuous wave Doppler to see tricuspid regurgitation, which in this case we don't. Continuing with this peristernal view, we tilt the transducer upwards, and then we see also not very good in this case the pulmonic trunk, so the pulmonic valve and the RVOT. Focusing on the valves, we have to zoom in on the valves. First of the valves is, in this case, because I see it now, the mitral valve, I see that the mitral valve looks overall normal. There is atrial fibrillation present, most likely we do see it in the ECG we have, and also how the overall heart and contraction is moving. And we do see one interesting finding. So here this is the anterior mitral valve leaflet, and in the case of a thickened myocardium, we have to look for a SAM, as so-called systolic anterior motion of the mitral valve. And here we see it that the chordae tendineae are inserting at the papillary muscles, and you do see the LVOT. And when we activate color here, there is somewhat a turbulent flow. So we have to keep that in mind to later evaluate if there is relevant LVOT obstruction present. Then we have to also take a look at the aortic valve. In this case, it's harder to see, but we can appreciate that the aortic valve looks without severe pathology. Continuing, we have the transducer oriented to his left, to his right shoulder, We rotate the transducer clockwise towards the the left shoulder. And we try to keep the aortic valve in our field of view. So you can tilt and during turning a little bit, but be aware that you do not tilt too much, because otherwise you will simply lose the image. It doesn't matter that much when you're used to echocardiography. Of course, you can also start at the midventricular or the mitral valve view, but initially I personally want to see the aortic valve. And in this case, the aortic valve seems to be okay, but it's relatively hard to see. For another atypical view, we have to rotate the transducer a little bit more towards the left side of the patient and tilt the transducer upwards to see the pulmonic trunk again. And here we do see the pulmonic trunk, and we also can activate the pulsed wave Doppler to measure. Here we have a measurement of the RVOT outflow, so the right ventricular tract outflow, and we can measure the RV, of course, how the outflow is happening, how is the signal normal, but we can also measure a so-called pulmonary acceleration time, so the time from the beginning to the maximal flow, to see if there is a likelihood of pulmonary hypertension. Then we continue with the area of the mitral valve, where we do see again here the anterior and the posterior mitral valve leaflet, and we also see that the mitral valve, the anterior leaflet, at least parts of the chordae tendineae, are moving towards the LVOT. This is a so-called SAM, a chordal SAM in this case, because we do not know if there's real obstruction present or not. So we can also use color Doppler to see if there's elevation in the flow, and we also can use M-mode. M-mode is a rather old measurement, but still we can see that there is at least chordal SAM present. But we have to continue with our overall evaluation of the heart. We can also try, just for demonstration purposes, to go back and use the M-mode also in this area, because the M-mode simply shows the structures over time, and here there is this SAM phenomenon present. But be aware that a chordal SAM, or really the LVOT obstruction, it doesn't really matter. So the M-mode just depicts the structures you see. So that's the mitral valve, the opening, and then you have this pulled motion from the chordae tendineae towards, here was probably the best signals, towards the LVOT. Then continuing, we have now the mitral valve. We continue towards the papillary muscles. We have here the papillary muscles, the posterior medial and the anterolateral papillary muscles over here, and then we can even tilt downwards until the apex. We do also see the right ventricle over here. Continuing with our evaluation of this patient, we move to an apical view. Bisschen her zu mir, genau. So we have to change his position a little bit, and then we start with an overall 4-chamber view. So we want to see all 4 chambers. We have the left atrium, the right atrium, the left ventricle, the right ventricle, and we save this image. You can also try to see if there is a pulmonary venous signal present. So we need to lower probably the PRF of the color Doppler. We need to use pulsed wave Doppler, and he also has atrial fibrillation. So, and the signal is not very good. So this we cannot evaluate, but this is how you would do it for the evaluation of, for example, diastolic dysfunction. You see the right upper pulmonary vein, and the right lower is basically never seen, and here would have the left upper and to some degree the left lower, and here the left atrial appendage. But in this case it's not a very good signal. So we save this loop, and then we continue to the mitral valve, and we can also change the color Doppler in length, not in width, to see the optimal signals. And what we can see is that there are some turbulent flow overall in the left ventricle present. So before we continue with the turbulent flow, I would suggest we go to the right ventricle and the right atrium, and we see the right atrium is quite nicely depicted over here. It's not the best view because he's really hard to scan from a right ventricular side, and we see the right atrium over here. Furthermore, we can measure the right ventricular function with M-mode, but in this case you see again the limitation of M-mode, because that's the so-called TAPSE. It looks normal, but to measure it is actually not entirely clear, because we simply have artifacts. But we can measure it We can save it, and then we continue with a tissue Doppler measurement. We use the tissue Doppler and measure a so-called S prime. In this case, it's normal. And I also always save a diastolic tissue Doppler signal of the right ventricle. Then continuing, we will evaluate the right ventricle and the tricuspid valve furthermore to see if there is a possibility to measure TR. And then we use the continuous wave Doppler, and there is actually no way we can see the signal optimally. Using it like this, so changing the gain settings of the Doppler, you shouldn't do it, because when you do it like that and you do not have a signal, you simply cannot really measure it. You do not know where you measure, and normally we do overestimate the gradients anyways. So we have to continue with the left ventricle, and we tilt the transducer a bit upwards. We can also do it downwards, where we see the coronary sinus over here, and we can tilt upwards a bit, and there we see the left atrial appendage, you can see here, and this is the aortic valve, so a 5-chamber view. This we also measure. We keep in mind that the 5-chamber view is essential for the evaluation, because here we can use continuous wave Doppler across the aortic valve to see if there are relevant gradients. Let me just put the signal in the middle so that we can see the signal really nicely. So this is moving inwards, the ventricle. This is actually during the IVRT, so the isovolumic relaxation, and then during diastole. And here we have the systolic measurement. And here you see there are two signals. Here's a signal and here's a signal. So these two signals we have to understand. And how do we know where actually a gradient is? We can use pulsed wave Doppler. So in this case we can start, for example, at the aortic valve. That makes sense, because when we optimize our setting, we do see that in the aortic valve, of course, there is turbulent flow. You can also see the signal is overall incomplete, so we have to move a bit backwards to reach our LVOT. And here you can see we are now in the LVOT, and here's also a relatively large signal. So this is also our LVOT signal we have probably seen before. Now we move inwards the ventricle and see what we can depict here. And here we have the inflow, so the E wave, and also the signal. Here we have the signal in the ventricle, and this is more also a dagger shape. So there's also an interventricular gradient, but it's not very high. So 1 meter per second, this is not relevant. And like this, we can move more towards or inwards the ventricle. Let me reduce sound a little bit, but we still want to hear. We want to hear and see what the signal is like. And here the atrial fibrillation, there was a slower AFib present briefly. And here we also see there is a sort of a gradient, but it's also not that high. So we have a patient with a thickened myocardium and several gradients we have to interpret. The midventricular, inner ventricular gradients, they can be, or there can be patients who are really symptomatic. But overall, in this case, we mainly have an LVOT gradient, and there we simply can take a quick look. There are already measurements, but the automatic measurements I don't want to do now. I simply want to see how high is the gradient. It's in between probably 12-13 millimeters of mercury. So this is not a high gradient. We will measure everything after we do the scan, but what we want to do additionally is we want to stress the patient a little bit. You can do it on a treadmill, but you can also do it simply with a stress ball, or also with the gel. So kannst du das bitte nehmen? So we tell the patient to take it and then just pump, 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 pump. So keep it closed, otherwise you will get a little bit of gel everywhere, which is also not optimal. And then look at the heart rate. The heart rate should rise 10, 15 beats per minute. The problem is in his case, he has a beta blocker therapy, and so it's not initially rising that much. But what we can do then in the evaluation, we can use continuous wave Doppler and see again how high the gradients actually become. So there was one, So there was one which was a bit higher, but overall during his atrial fibrillation, we do see the gradients. We also don't want, this is a very, very quick measurement. The gradient is around 15 millimeters of mercury. So 2 meters per second, 15 millimeters of mercury. This is not a relevant gradient in the LVOT, but we also want to measure this one here, so that's still a relevant gradient, but it was during exercise, it's below 50 millimeters of mercury, so still that's not a big problem. Overall, the patient did drink very little today, so probably he should drink another glass of water. But when we started, I also scanned him and he hadn't a glass of water at all, and the gradients were interventricular way more, so already the ventricle is feel better. So now we continue, because we also want to do strain imaging, of course. So now we have an optimal 4-chamber view, and we save the optimal 4-chamber view. So it's focused on the left ventricle. Then we continue to the 2-chamber view. Bisschen einatmen, so inhale, Luft anhalten. So I also try to inhale and then keep and hold my breath to see how long the patient actually can do it. And here you see the apical long axis view. It's relatively hard to see. Weiteratmen, perfect. And what we can also do is just use a apical 5-chamber view. And I use more than one view to see what's actually happening. Nochmal einatmen bitte. Stopp. Und die Luft anhalten. Especially in this case, when the imaging, und weiteratmen, image quality is not optimal when you have atrial fibrillation, it's better to have more views in my point of view. One thing I forgot initially, what we also want to do is an optimized image of the left atrium. We do see the left atrium over here. This is the left atrial appendage. We also have the pulmonic veins entering. So also in this case, you can see and measure the pulmonary venous signal. And here it would be, but still it's also here not an optimal signal. So, but you can see it in more instances. Then furthermore, in the apical long axis view, we also want to see, like in the 5-chamber view, the gradient. And I now switch back to the optimal PRF. So it was before a little bit low for the pulmonary venous signal, but here also can try to measure the gradient over here. And we have the similar image. So we have interventricular, also in diastole some movement, and here several, and he's breathing, so we have different signals. So this is really RVOT, and here is the interventricular gradient we see as well. So the interventricular gradient is steeper than the LVOT gradient we see. So continuing with our evaluation, we also can use the multiplane imaging and then focus still on the left ventricle. We can use a 3-planar imaging and nochmal einatmen. Stopp, und die Luft anhalten. So he holds his breath and we try to optimize also the angle we have for the 3 individual loops. In this case, it's not that easy, so it's not an optimal image. Weiteratmen. And probably we cannot really use it. Another thing we have to be aware of is that the frame rate is always optimal. So in this case, I didn't adapt it because the image, it won't be enough for strain imaging, but you can also adapt by just using a higher frame rate so that it's optimal for strain imaging. It should be in the range of 50 to 70, maximally 80. So 40, below 40 strain is not even possible to measure in these machines, most likely. And we want to continue even further because we have some more things to do, because I also want to see at least I want to have a 3D data set. So here we have the 3D image. We can use the multi-slice and then we see the ventricle from the base to the apex. Here we are even in the atrium, and here we want to have the left ventricle. And you see that image quality is not optimal, so we can do 2 things. So he can inhale again, and then we can also use more than 1 beat. So if you have only these 3 beats, then it won't be optimal, but we reduce to 1 cycle. Und bitte wieder einatmen. Stop. And as he inhaled, our image is a little bit better. Now we see it better, and then we use the multi-beat. So now it's calculating 6 beats, it's like in MRI, and then we can save it. Weiteratmen, perfect. And also we tried again in this case, normal weiteratmen, to have the optimal image first. Bisschen einatmen wieder. Stopp. Und so die Luft anhalten. Perfekt. And then multi-beat, of course the patient should be able to hold his or her breath, of course. But here we have a nice image. Perfekt, weiteratmen. Now we have the 3D data set. The one thing that is still open is one thing you can sometimes easily forget. Diastolic dysfunction. We also want to see it in this case, and we have the E wave we have to measure. And of course we need to use the tissue Doppler, not only for the right ventricle, but also for the left ventricle. Here we have the E' medially and the E' laterally. And you also hear that's a nice tissue Doppler signal, and they always have more than one signal to compare in atrial fibrillation what's the average signal that you should overall do. Now, as we have implemented all of this in our imaging, the one thing we still want to do is contrast imaging. For contrast imaging, we need a contrast agent. We have it here. In our case, it's SonoView. We need an IV access for the patient, and we need a specific preset. So this is called the LV contrast preset. This makes the, I just show you, I just want to show you a normal B mode, and you see that this is all very blurry. That's the optimal contrast preset. So you see that the mechanical index, all the gain settings and much more settings are optimized for the bubble study. So this is a left ventricular contrast imaging. So we now use the contrast agent. We only need 1 milliliter, not much more. We just take it out and then we administer it to the patient. And as we only have one patient today, we can attach it again. And normally you can have this for at least 5 to 6 patients. And danke dir. Now we can look at our image, and we already see that the contrast is in the left ventricle, so it's passing the right ventricle. We also can get a glimpse of the right ventricle seen over here, but especially we want to focus on the left ventricle. And I personally also prefer rubin. It's a better color for my eyes, so I'm used to it, so we're using it now. In this case, you can also, and now we want to have 3 cycles again, we also can use a yellow contrast. This is not my favorite contrast setting, I have to say, even though I see it good. So I prefer the rubin, so the red contrast study. Now we also save this, and when we have the 2-chamber where we optimally can see the entire cavity of the heart, and we save it. And also in this case, the apical 3-chamber view, the apical long axis view, we see everything. Noch einmal einatmen bitte. Danke. Und die Luft anhalten. Inhaling again helps. And that's the 2-chamber view. And again the apical 4-chamber view. Perfect. Weiteratmen. Danke. And furthermore, the last thing we still can do is we can also use the triplane mode in the contrast setting. And in this case, you see it's better. So still we would have to adjust the angulation a little bit, and that's just then playing around so that you have it optimally. But in this case, I'm not too unhappy with what I see, so we can take it. And one more thing I want to show you in these high-end machines is you can use even 3D, 4D contrast imaging. There you need more gain, and here you have the cavity of the left ventricle. And also in this case, you can go to the multi-slice imaging and see from really the beginning of the left ventricular cavity till the apical regions that there is no aneurysm present, but this hypertrophied heart. So as we now finished our evaluation, we can summarize. One more thing I wanna do is I wanna show you the subcostal approach just quickly. You can, of course, the patient can lie in a supine position, but we simply continue now on the left lateral side, because just for showing purposes, here you have the heart from a subcostal approach, no pericardial effusion. Also the IVC is slim. Here you can even see in the greater depth the SVC. So we have the IVC and the SVC. Then the last thing we need to do, kannst du am Ruck anlegen bitte? Is scan the lungs. So what we normally do is we scan from anteriorly. We can also use a linear transducer if we have it, or we can simply use this transducer to see artifacts. We do not have any, and then we continue with pleural effusion, which we also do not have. So we would look here for the pleural effusion, left and right side. So to summarize this imaging, we do have myocardial thickening. So in our evaluation, it turned out the patient has a hypertrophic obstructive cardiomyopathy? Well, we started treating, of course, with beta blockers, and the first gradient we measured when the patient visited our hospital was during rest 75 millimeters of mercury. Now we remember what we measured now. It's way, way, way lower, so approximately 15 to 20 millimeters of mercury. We still are going to measure all our measurements, but now it's, for me, very important as we have the patient here, and he's receiving a new medication for the form of hypertrophic obstructive cardiomyopathy, Mavacamten. I want to ask him how he's doing. Also, jetzt noch einmal die Frage, wie geht's dir jetzt?
Super, so wie wirklich bin ich voll zufrieden und ich spiele selber, dass ich viel mehr kann unternehmen, dass mir viel besser geht.
Super, das heißt, dass insgesamt geht es dir jetzt wesentlich besser, als was wir begonnen haben.
Genau.
Okay. So to translate, he's feeling way better compared to when we started with the medication, and he's now able to do way more, has less symptoms, and also his heart is doing overall better. So the NT-proBNP levels were declining from approximately 3,000 to 1,200 nanograms per liter in our case, and he's receiving it for approximately 2.53 months. Also, we do not have actually a relevant gradient during exercise and rest. Now, as we have finished our evaluation of this patient with the hands-on part, we are going to move on and do some measurement.